What is going on, everybody? It is Mark Cargill, lead faculty and CEO here at Modern Pain Care, where we make you the complete clinician. Coming at you with another episode of the Modern Pain Podcast, where today we're going to talk about a near and dear topic, because I get sometimes accused of being a manual therapy hater, even though I went through fellowship and did all the manual therapy hoop jumping. We're going to talk about the lumbar manipulation, CPR, because it's been one of those topics that I've had definitely an evolution of my views on the CPR as I've been introduced to them over time. Again, I've been fortunate enough to know some of the folks that were involved in some of those studies, and I think all of the intentions were amazingly good and continue to be good around some of that, but maybe some weaknesses, and maybe it didn't really, come out the way we thought. Kudos to those who tried to put it together, something that would give us some, major shift of how I think what it did do, and we'll talk about it, is it made manipulation less of a scary thing to incorporate into our practice as physios. Some of us were doing manipulation quite a bit, but others maybe not as much. So there may be some benefits of it, and I know others think manipulation's the devil, but whatever. But we'll talk into detail about it this week of the lumbar manipulation CPR, because it's one thing that I think continues to get hammered on the OCS exam and DPT programs, and I think there's definitely some nuance to the discussion to be had, which we're about to have with our co-host, Jarod Hall. How you doing, man?
I'm doing good, man. I'm actually really excited to talk about this particular episode because it's been on my mind for a long time, and I've talked to individual people about it a lot because as you know, I teach in a PT program, and I run or help run an OCS prep program. So these clinical prediction rules and these treatment-based classification systems and all this sort of stuff, they come up a lot because they are very, rigid and outlined. So they're really easy to write test questions over. And when you write test questions over something, students, test takers, start to think that, well, this is exactly, the best thing since sliced bread, because you're getting a million questions over it because it's really easy to write questions on. So then people start algorithmically applying these things to every patient that walks through the door as a determining factor on whether or not, to do a lumbar manipulation in this particular example. And I think that there's some, you mentioned the people who created, the researchers who did the hard work, really, really tough work. Like, let's not, undercut how difficult it is to do these studies, and went through the process of getting it published. And they had fantastic intentions, because they're trying to reduce massive variability and non-evidence-based practice in our profession. So kudos to them for that. We absolutely need that. But you're right, there are some issues with that have reared their head when you really take a deep dive into what those clinical prediction rules look like, and especially treatment-focused clinical prediction rules in general. What's your experience with the whole evolution of lumbar manipulation and clinical prediction rules and that sort of stuff, Mark?
Well, those of you who've listened to anything, you've heard probably my journey of, like, I had this existential crisis in the profession where I just could not convince my guru hands were ever going to get to detect millimeters, and then those friggin' millimeters made any sense that it was going to explain the complexity that I was seeing in the clinic. It just made no intuitive sense to me that I couldn't continue down that rabbit hole. So I was ready to quit. And then got introduced by some colleagues, like, hey, there's some research coming out. There's some more clinical guidelines that are going to help. And I think if you jump into this fellowship, which was Evidence in Motions Fellowship, still eternally grateful for that fellowship. It really has leveled up a lot of my clinical reasoning and critical thinking and all that different things. But it was very much founded based on the treatment-based classification system, and a lot of the CPR folks that were writing these CPRs were part of the faculty in Evidence in Motion. So I definitely had this thought, oh man, now I have this solution. Now I have, manipulation is no longer a fuzzy when. I got this black and white way of determining who gets manipulation or not. And again, black and white, that's probably a little bit extreme, but I mean, it does tend to risk yourself getting into a black and white clinician-centered way of practicing. And then, so it became like, hey, we got these factors that'll, manip. We did. So let's talk about the factors before I get into too far. Pain lasting less than 16 days, no symptoms distal to the knee, a FAB-Q score less than 19, internal rotation of the hip greater than 35 degrees for at least one hip, and then hypomobility at least one level in the lumbar spine. Obviously there's some subjectivity into that a little bit, but and then Julie Fritz came along, and I think she did it in a more of a primary care setting where she found that if you just strip it down to pain less than 16 days and pain that doesn't go distal to the knee, folks tend to respond to that. So that became kind of the deciding factor for a lot of folks to enter in manipulation into the equation, and definitely was a biased approach for me, because I just then wanted to manipulate a lot of people, because although there's not a lot of folks that I was seeing in certain settings at less than 16 days. I've worked in persistent pain settings where that 16 days was long ago, but there were definitely times where you'd occasionally see those folks, and it was thought, okay, manipulation is a solution, but then as research has come out, it shows that manipulation is that CPR is one way to identify people that are going to respond to multitude of interventions and different things. There's been some studies, but yeah, my evolution on it then came to as the research has shown that it's not really making that you should be doing any, there's a lot of choices of interventions. Again, a lot of what I think people get all sad about, how there's no, amazing Kool-Aid intervention that I can jump on and fix all my patients. To me, that's what makes clinic fun. That's what makes things going in, where you qualify the intervention, whatever it may be that a CPR gave you or whatever, doesn't mean diddly squat if it doesn't fit that person that day in front of you. And that's, to me, what should be priority, not like I'm going to shoehorn these patients into a CPR and they're going to, by golly, get manipulation. If you create a scenario and it's a shared narrative and a shared agreement that that's a good way to go about treatment that day, fine. And I still manipulate. I don't do much manipulation. The lumbar spine, I probably manipulate more cervical and thoracic. Just tend to find more success going repeated motion, patient self-loading strategies. Not to say, again, I've manipulated a few people this week in the lumbar spine, but we can talk about some of the decision-making on that. But again, I think the research has really shown that these kind of CPRs aren't really well suited to help us as much as we thought they would clinically, and they haven't given us the panacea or in utopian clinical life that we can really just use them to determine what patients should be getting. And you mentioned this treatment-based classification system. It's a good way to algorithmically think and give yourself some thoughts, but man, humans don't fit algorithms, man. Never will. So you need to be able to fit that TBC, or maybe you do MDT, or maybe you do who knows what. I know Linda has maybe a different way of reasoning, that it needs to qualify the person in front of you. And that's where, if anything I've learned about CPRs, is it's just one example of how you can't shoehorn people into population statistics, that you need to bring population statistics and see if it fits in the N=1 in front of you. And to me, that's been, I guess, the biggest where I've ended up on the back end. Like, don't use it. I can't really say I think about it yet, but it's a thought of maybe, and that's about as much as I go with. It's never a like, hey, this is the decision because this no pain below the knee and pain less than 16 days. And I've seen some of this craziness where people say, well, then you're doing harm to your patients because numbers needed to harm because you're not doing it. You're doing your patients a disservice. Come on with that. Come on with, that to me is just crud. That's just bad, ways to start talking about it. That's, to me, marketing. That's saying, hey, I teach it. Therefore, if you're not doing it, you're doing your patients a disservice. Ridiculous to me. And I get pissed off, frankly, because that to me is clinician-centered, selfish care. That's not patient-centered care. And there's no data to say that we should be absolutely if manipulation is your desired way to go about get change in the clinic, fine. Just get over it and move patients off plinths. If it's mobilization, fine, get over it, get people off plinths. If you like the needle, get over it, get people off plinths. I don't really get excited about what latest intervention. I'm getting on the soapbox, and I knew I tried to prevent it from happening with this episode, but take me off of it, Jarod. Where are you at with the whole CPR and where you've kind of evolved with it over time?
Okay, so I think what would provide some value would be spending a little bit of time talking about how CPRs are developed, and then maybe talking about the individual components of the CPR, and we could give a little bit more explanatory depth to why we have these feelings, right? So I'm going to provide a rough overview that is overly simplified on how this CPR was developed. So you take a cohort of patients, and this is as many patients as you can get to achieve the appropriate research power, right? So you want to measure everything on these people. So every person that comes through the door that qualifies for your study and that you do a manipulation for, you measure all of their ranges of motion, you measure all of their strength, you measure all of their symptoms, you measure all of their history and how long it's been going on. You do multiple different questionnaires. You make data points out of everything, and then you apply your treatment, and you come back at the end of the study and you look at who got better, and then you do this, it's called a derivation study, right, where you're looking for all of the factors that seemed to be in common between the people who got better. So that's what happened with these particular factors. Out of the people who got the most better or consistently got better, we saw that their pain was on average less than 16 days. We saw that their FABQ, I think it's work subscale, was less than 19. We saw that their hip internal rotation was at least 35 degrees on one side for some reason or another. We saw that, they had stiffness at the lumbar spine with PA mobilization, and we saw that they didn't have pain below the knee. So these 5 factors showed to be common between the patients who got better. So kind of what I call this, or what I liken this to, is equivalent to the Texas sharpshooter fallacy. If you're not familiar with what the Texas sharpshooter fallacy is, it's some guy pulls out his gun and he shoots the side of a barn a bunch of times, and he walks up to the barn and he finds the 5 holes that are closest together, and he draws the bullseye around that afterwards to show that he has hit the bullseye with all of his shots. He's on target, right? But really, he just threw a bunch of crap against the wall and went afterwards and drew a circle around it and said, I have the answer, right? I hit the bullseye. So I think that it's a little bit of a post hoc way of thinking about it, and you get some kind of interesting components that don't necessarily have any, we'll just say don't make a lot of sense, that don't have any clear biological plausibility as to why they should be part of this clinical prediction rule. So if you look at symptoms less than 16 days, well, that's a really, really easy way to come up with a treatment that gets people better. Is if you say, if you've hurt for less than 16 days, and I do this treatment and I come back and measure you at 6 weeks later and you're better, it must have been because my treatment made you better, right? But with low back pain, we know that the typical course of an acute bout of low back pain is about 6 to 8 weeks. And we know that about 70 or 75% of people will get a tremendous amount better within 6 to 8 weeks. So if your symptoms have been less than 16 days, I do a manipulation, or I do a mobilization, or I do dry needling, or I do taping, or I do a rain dance with a gong, dancing around your head, odds are you're going to be better next time we come back to measure your symptoms. So that's my problem with that. Secondarily, as physical therapists, in a lot of states not having direct access, and people typically going to their primary care and having to go through referral processes and all that sort of stuff, most people don't get to us within 16 days of their symptom onset, in a lot of different places. Unless you are one of those people who are lucky enough to have a lot of direct access and you're doing a cash-based practice, you might get these people a little bit quicker. But that's a little bit of a problem with it, but that's completely different than the fact that that time frame just sets you up for success. And then, internal rotation of at least 35 degrees. Well, what's the biological plausibility for having hip internal rotation of greater than 35 degrees on at least one side? Doesn't matter which side, doesn't matter how much greater, doesn't matter anything that's going on, doesn't take into account the subjectivity and the measurement error of goniometry, right? So you got a problem with this because there's no biological plausibility on this hip internal rotation on a random side of at least 35 degrees. That's just what worked out in the wash. FABQ subscale of less than 19, I like that just because it pulls in like how much fear avoidance is there. And it kind of lends itself to maybe weeding out some of the people that have high catastrophization or highly sensitive systems, that they may have pain that lasts longer, right? They may be in that cyclical persistent pain type of scenario where, yeah, they're probably not going to just get better if you manipulate their lumbar spine because their issues are way more complex. Pain that doesn't radiate past the knee. I mean, I think that this is fine. I know that that probably came about because, if pain radiates past the knee, that's more likely that there is some sort of neuropathic component, and doing a lumbar manipulation may or may not affect that neuropathic component, and those things maybe tend to last a little bit longer, right? If you've got a significant disc issue, or if you've got some sort of significant, lumbar stenosis type issue, doing a lumbar manipulation, that's not going to fix up, that sort of thing. And then what was the other one? Oh, the stiffness with prone PA assessment of the lumbar spine. Let's not even get into how ridiculously unreliable my subjective assessment of another person's stiffness in their lumbar spine is. The whole motion palpation concept has been thoroughly debunked, because what you say is stiff, I won't say is stiff, and what I say is stiff, you won't say is stiff, and we're not even really that reliable at palpating the correct lumbar levels to assess that stiffness at. So I have a little bit of a problem with every component of this and the way in which it was designed.
And let's not forget Tasha Stanton's work, where she said that even the stiffness that patients perceive doesn't relate to the mechanical characteristics of stiffness in the spine. It's more of a protective inference into the, a protective way your body will produce sensations in an area, versus there's some that it aligns well. So again, there's just a lot that is not really going to be reliable with motion palpation and hypomobility. I wonder, how hard is it? I mean, any clinician that was facing, God, I need 3, I got 2 of these, and they're left with hypomobility of the lumbar spine. How many clinicians that are manipulation oriented had a hard time finding a hypomobile segment? I mean, to me, it's just like you kind of find what you're looking for type thing with some of that stuff. And just because you want to get to a treatment threshold. And again, all this stuff is motivated on great stuff. We're trying to figure out best ways to find populations of patients that might respond well to something. To me, it's a fruitless pursuit. You're never going to find a homogeneous population of humans. You're just not going to. And it's not that there might be some characteristics we can find, but again, to me, and I remember some of the clinicians who I was fortunate to get mentored with getting frustrated with, now all of a sudden research is the new guru in town, because we're stripping clinical decision making and making studies and research to do clinical decisions. And again, I think obviously the nuanced approach is you bring these CPRs into play as one little source of information that, again, it needs to be qualified with a unique person in front of you, that whether that means something to the patient. But yeah, I think you nicely laid out some of the issues with those factors that go into CPR development and things. What are the things you see with like DPT students, maybe younger clinicians as well, like struggles with them as far as figuring out where this stuff all fits? I know you do your OCS prep course, and different things like that. But where do you find like the misconceptions or misapplications lie in the younger clinician population?
I feel like these clinical prediction rules and these thought processes have been driven into their head, because they will be tested on them a lot. They'll be tested on them on their MSK tests. They'll be tested on them on the NPTE. They'll be tested on them on the OCS exam. So they are driven into their head repeatedly. And I find that a lot of times these students and these younger clinicians especially, they start thinking in a product type of mindset, and God love Jason Silvernail for putting this thought process in my head of product, process versus product. But they start thinking, oh, look, like I spun the Rolodex and it hit the algorithm just right, and it's got this clinical prediction rule, so I'm going to apply this treatment to that person. I'm going to apply it. I'm going to apply this product. I'm going to answer this question with, the clinical prediction rule, and they get zoomed in, right? And they forget about the person. They forget about system-wide sensitivity. They forget about the interaction between the clinician and the person. They forget about the environment that the person lives in. They forget about psychological factors that may be playing a role. They forget about where that person exists within their culture, and they are zooming in on saying, oh, this person has low back pain and they have internal rotation of 35 degrees and it doesn't go past their knee. Manipulation, why aren't you getting better? Manipulation, why aren't you getting better? Or what is probably more common is manipulation. Hey, a few weeks later, this person got better. Must be because I'm a super badass, highly skilled Jedi hand trick manipulator, and it's not because of other factors, right? So they see this pattern. It's the whole concept of patternicity. And if you read any of like Michael Shermer's books on human patternicity and the way that we draw connections between non-related events and then use post hoc reasoning to justify them and decision making based on seeing these patterns where they maybe don't exist, it's just kind of what I see in a lot of these clinical practice models, because it's gotten to the point where, you know, if things are prescriptive like that, it takes away a little bit of the really strong critical thinking and clinical reasoning process that is human-centered, person-centered, patient-centered.
Yeah, hard to argue with that. And teaching in a DPT program as well, it's always, because students strive for black and white. That's how they're tested. They're tested on a black and white way of looking at things. And again, I don't think it's bad that students are aware of these things. I think they should also be equally aware of the limitations with them, of exactly the conversations we're having here on this podcast. Is because if you come out with this like, oh my God, the solution is here. And I honestly, I don't, maybe that's an extreme way of how I perceived it, but I did feel like, man, now we got this, I don't have to do the Jedi hand tricks of millimeter palpation to determine treatment thresholds anymore. Now I can use that. And again, it still can be helpful of that. Yeah, maybe this person's, more likely to respond to manipulation. But again, and that's the hard thing with DPT education, is you can't teach clinical reasoning. Paper cases do the best we can, and it's nothing wrong with that, and we need those things. But until you start interacting with real humans in pain that are right there in front of you in the flesh, and you start testing some of this stuff with a process, as Jared said, not just flipping the Rolodex to a product, and because that's where students struggle initially when they make their initial forays in clinic. I know this student did when he was in that stage. I wanted to go down the algorithms of, they fit that algorithm, they go here, and then it freaking backfired massively. They hated it. It didn't go well. They're worse next session. So again, being able to take these CPRs for what they are, they're not anything amazingly special. They might give us some thoughts of maybe populations that are going to respond to a multitude of interventions. I think it was Schenk and colleagues that did some studies that looked at a lot of the manipulation CPR are equally respond well to specific exercise, and there's other studies that have been done that show that it's not unique, that manipulation is the only thing that these folks are going to respond to. But again, it just gives you some information for a patient that can lend you to think, okay, maybe this treatment's on the table. But then again, it becomes like the dialogue with the patient. Is it something? What are your thoughts on us trying this? A quick stretch, going to give you a pop, hopefully going to, basically his job is to give you some pain relief and improve movement. Tends to be temporary unless we teach you some things to get off that table and moving well. So I want to teach you some things, but what are your thoughts on that? And if absolutely no, I had a horrible experience with the last PT who did that, or yeah, absolutely. Again, depending on where the patient's at, but again, it qualifies to that person in front of you. Other things I would just add on to what you said is just the equipoise of the personal equipoise of clinician. Like if you live in a world where you have letters that are like, look at my manipulation things, and you're cranking out videos of this amazing, I still get frustrated with those videos of like people on Instagram and stuff of like, look at this amazingly executed manipulation, and there's just like this, paternalistic, guruism to the video of look at how amazing this is. It's off-putting to me. I understand the thoughts behind it. We need to be good technically. It's just the like, I don't even know how to even say it, just like the way we still are so freaking enamored, and we just like puff our chests up and like want high fives after we manipulate people, is just, to me, is like, when are we going to get over it? Like, it's same thing with needling. I don't have anything against, I have a lot of colleagues that do both needling, manip, but who freaking, like, let's get people off tables. When are we going to realize that just, modulating symptoms on tables just isn't doing it for our patients? It isn't. But and I'm going to go, okay, let's get our anecdotal stories. Well, it worked for this patient where nothing else worked. Sure, yeah, you created a context where that situation, it worked. Great. What did they do off the table? Okay, good. But anyway, I think sometimes we just search for justification for our biased approach, and that's where, why don't we use a nuanced approach where we fit things to patients and not fit patients to us? And I just think, as you've pointed out, we risk a lot of biased approaches when we try to just build a mountain of research to support our worldview, and CPRs can build that mountain for you. And again, if you look at the studies that say how well are they validated, how well is it, what are these impact analyses that should be that final step, what are we looking at? It becomes a big there's not much going on that they're really adding amazing, again, helpful things that we've learned and things, but it's just time to move on. Time to move on to again, I think person-centered care is, humanity's bringing all that stuff into things. And then also still being able to skillfully add those techniques without the ridiculous complexity that some of this manipulation stuff goes to. Like, you got to do level 14 of a manual therapy curriculum to be able to kiss the ring of some guru who's saying that you've now been knighted the knight of manual therapy. That's ridiculous. And I think you can be, in a weekend course, you can get good at manip if you get some good instruction. And there's a lot of people that are doing it. Our friends at ICE do it. There's other folks that are doing great on the manipulation education. But just, again, learn it, and then it's a part of the process possibly. But I think we have to recognize it's just not solving the problem, and it's not going to. There's not one intervention. I just think we got better things we can look at and focus bigger picture with patients. But anyway, that's my thoughts, Jarod. What about you?
No, man, I think we've covered it. I don't want to beat the CPR horse, right, to death too much. But it's just it's having a framework, right? It's understanding that care with the patient is dynamic and everyone will be different, and that's what we're trying to get across. And you and I work in this world where we teach at a university level, and we teach in specialization programs, and it's difficult to walk in that because everybody wants black and white. But that's also why we created Modern Pain Care and the Complete Clinician Supercharged program, is so we can actually spend time with people over a long course of time, over several months, working with them in their practice and helping them see the gray instead of the black and white, helping them have a framework and a reasoning process that they can actually apply in clinic and morph themselves in their interaction to that particular patient at that particular time, and get feedback all along the way in small group discussions and direct one-on-one mentorship calls and that sort of thing, just because learning takes time, and learning is a process as well. It's not just a product that you go buy on a weekend course. It's this thing that takes active engagement, and then it takes reflection, and then it takes correction, and then more active engagement, and then more reflection and feedback, right? It's almost like patient care, where it's not just this product, it's this process, and it takes complex nuance, small adjustments and changes and feedback and shared decision making.
Yeah, and as Jarod said, that's the whole point behind the program we created with the Complete Clinician Supercharged. So check it out at modernpaincare.com/supercharged, and you can see if it might be something that would be worth it in your practice. Because again, if you want to learn to develop the process, if you want to learn to when does the CPR fit for a patient, when does manipulation work for that person that day, do you want to learn in your clinic? Because stripping yourself out of the context of your clinic, going to a weekend course, getting your tires pumped up about all these techniques, and then having to figure out how does it fit to the unique person in front of you. That's the classroom we're trying to create with this coaching program, is where you struggle applying it in real time with the people that are having problems in your practice. Or why didn't this CPR work? Why didn't it fit for this patient? They were classic. They had all 5 of the 5, yet it sucked. They were worse afterwards. Why? What did I do wrong? What could I have done better to apply a more nuanced approach to doing it versus a research clinician biased approach of patient care? And that's what we teach. And if you want to check it out on that webpage, and we can have a conversation, see if it's a good fit for you. But I think getting folks on a path to start learning a process, and thanks to Jason Silvernail and others who've given us the kind of kicked us in the butt to start thinking bigger picture and looking at patient care to the breadth of what it truly is, and not getting so enamored with the latest shiny intervention that's popular in our profession. Nothing wrong with bringing in new interventions. I think we have no issues with that, and we'd encourage, the continued pursuit of ways that can better help people in pain. But we're pretty sure that there's been a lot of time where a lot of interventions have come and gone, and nothing's really jumping out to the forefront as amazingly special. But that's why you got to learn a process to figure out what tools work for that patient that day. So yeah, we'll finish our episode with that. Hopefully you found some value in it. Hopefully my blood pressure is coming back down from getting all fired up about CPRs. I know I'm going to get probably people are going to listen to this and think, oh God, here's Cargilla, the manual therapy. No, I think manual therapy has just gotten led astray with some of the, pushes towards one biased way of looking at human beings through, having to manipulate it through passive movement approaches. Can be one strategy. Just I think we need to do better and look bigger picture on people and tunnel vision on any intervention, be it manual therapy, exercise, or whatever. So anyway, hopefully that was valuable to you guys. We'll be talking to you at the next episode. If you have any questions, concerns, remarks that you want to send to Jarod and I, hopefully not hateful in nature, just feel free to reach out to us on social media, and we will talk to you next time.